Hi, I'm Dr. Deepak Megur, and he is a 75-year-old gentleman who has this white hypermature cataract. 8 months back, he has undergone a pterygium surgery with conjunctival autograft. We can clearly see the corneal scar here, and this is the area of the excised pterygium. Now it has got the graft. The idea was to do the cataract surgery 2 months after the pterygium surgery, but the patient just disappeared, never turned up, and now he's presented almost 10 months later with an hypermature cataract. The markings are made. Patient is having significant astigmatism, and we're going to use a toric lens in this patient. The side ports are made, the active capsule is stained, OVD is put into the eye, the main incision is created, and time to perform the rhexis. Rhexis also has turned out to be decent sized. The real challenge now is to deal with the nucleus. As the liquefied cortex escapes out, I realize that the nucleus is quite mobile and also quite dense. So the strategy which I'm decided to use is maybe create a deep trench and then try to chop. The two complexities in this case at this present which I'm facing, again two reasons. One is the corneal scar, and also the liquefied lens matter has escaped into the antechamber mixed with OVD, and it's also hampering the visibility. The second thing obviously is the mobile and the dense nucleus. So I'm trying to improve the visibility by putting some OVD on the cornea, and it just marginally improves, but still I'm very skeptical to go forward. You can see I'm trying to stabilize the nucleus. I've increased my power. I feel that I'm pushing at the nucleus and showing at the nucleus rather than doing the trenching in a very controlled and gentle manner. I'm just trying to focus a little bit more, aspirate out some of the cortex which is there in front, and try to improve the visibility. So it's important that sometimes when you realize that you're not comfortable, try to identify what is the problem and try to set it right before proceeding blindly. So I think that I'm seeing a little bit better. So just go in and start to redo the trenching again. So once a little bit of trenches are done, again I get those loose lens matter, and I'm not able to really appreciate the depth of the trench well enough. And because it's a dense cataract, I wanted the depth to be at least 70% so that I can hold the nucleus well before chopping it. Since the nucleus is mobile, so things are not getting easier for me. So I come out, and whenever we have a little bit of a confusion in the mind or there's a lack of clarity in our thought process, just go back and inject OD so that the lens matter in the antechamber is pushed away and the visibility improves. So that's why I'm trying to do it now, and hopefully there is clarity within the eye also and in my head as well. I can see the pit now. The visualization is good, so I can go back and decide when to initiate the chopping maneuvers. So I'm just trying to deepen the groove a little bit more again. Again, please watch the second instrument. It's always supporting the nucleus so that the pressures are not transmitted to the posterior capsule or the bag. Again, important to use very low flow rate when you're doing these maneuvers, simply because we don't want the nucleus to be moving around a lot. The nucleus is again rotated and the trench is deepened a little bit more. So once I feel that it's okay and now I'm unable to crack, change the setting to chop mode, engage the nucleus quite deep enough, and then did the lateral separation maneuver. The nucleus is again rotated. Again, the nucleus is held very carefully at the central portion. It is quite deep, very much near the posterior plate. Chopper goes down right at the posterior plate, and then using multiple lateral separation maneuvers, the posterior plate could eventually be broken. Now I've got two large heminucleus here. I realized that the cornea requires more protection. Again, I'm going in to refill my OVD. Classically, I just use the dispersive OVD first, just behind the cornea, and then beneath it, near the capsular bag, I'm going to use the HPMC. Just want to reposition the nuclear fragments in the right way. Now is the time to perform emulsification. At this stage, I believe that the harder part of the job is over. We have broken the nucleus into two heminuclei. Further division of the nucleus should not be much of an issue. The standard settings would be like in a chop maneuver, where we're going to use just the longitudinal energy to hold the nucleus, and the chopper does the job for us. Important thing is to grasp the nucleus as deep as possible, at least quite a few microns below the surface, and then chopper goes down vertically and then laterally. Multiple attempts at lateral separations are required to eventually break the posterior plate. the same maneuver is being replicated in the remaining two-thirds of the nucleus. So eventually we have three small fragments of one heminuclei, and then these are being consumed using just the torsional energy. So time to deal with the second heminucleus. Again, I'm going to replenish some OVD into the eye. So now, since the visibility is quite good, I'm going to use an horizontal chop maneuver in this quadrant simply because the bag is empty. I can pull it centrally. It's easier for me to go and hook it around the nucleus. So when the nucleus is very mobile, the best chop technique to use is the horizontal chop technique, because the forces which are employed are much more physiological and it's extremely effortless to crack it. The only problem in this case, why didn't I use it as a form of primary chop, was because the visibility is not great because of the overlying corneal scar, and we have to pass the chopper under the rexus margin and then chop. So that will become a slightly risky proposition for me. That's the reason I resorted to this technique only after one half of the nucleus has been consumed. A little bit of cortex is there, which is just aspirated. I prefer to use a tangential mode of stripping of the cortex, especially while dealing with these hypermature cataracts, because we never know the zonules could be compromised. The bag is inflated with OVD and the planned toric intraocular lens is placed into the eye. Now, before aligning it to the desired axis, complete OVD removal from underneath the surface of the lens and within the bag is done, followed by removal of OVD in front of the lens. Then, with the irrigating handpiece in my left hand, the IOL is aligned to the desired axis. The side ports are hydrated, that's it, the case is done. So the two key points in this case is whenever the visibility is hampered and the nucleus is mobile, chopping becomes a little bit tricky. The most important part is to ensure that you are seeing well, clear of all the muck which is there in the antechamber. Use viscoelastic on top of the cornea, which provides a little bit of magnification and also clarity. And then when you're chopping, the most critical aspect is to bury the tip into the central core of the nucleus, not in the superficial part. So if we have a good grip, which is possible only when we hold and grip the core of the nucleus, that is at least many microns below the surface, that's when chopping becomes much more effortless. And finally, horizontal chop technique is a great tool, especially in mobile nucleus. Only thing is, it's sometimes intimidating to go under the rexus, especially in an opaque cataract and in an eye with corneal opacity. So that was it. Hope you found this helpful. Thank you for watching.